That's one of the most exciting introductions I think I've ever had, Paul. Thank you. It was really great. Thanks a lot for having me. And really delighted to be here and honored to be here with you all this evening. Thanks for the invitation and opportunity. Let me share my screen. Hopefully you can all see that. You seeing that? Okay, good. And you can hear me okay?
Yes.
Very good. Okay,
Yes.
terrific. Well, obviously, as Paul mentioned, I've done a lot of work in this area. I've been a researcher, clinician for all my career, 30 plus years now. And it's been a great journey in my career. And one of the things that I have focused a lot on has been recovery from addiction, how treatments work, what are kind of optimal treatments, and then how people not just stabilize, but how do people get into remission and stable recovery. And mutual help organizations are a key component of the infrastructure of recovery supports for individuals who have these disorders, alcohol and other drug use disorders, as well as family members. I think notably, last year marked a 50-year milestone, just to give you a little bit of context here in terms of the research in this area and what we've learned about recovery, addiction and recovery, as well as the clinical course and the role that mutual help organizations play, is that, that 50-year milestone was obviously a big milestone since the declaration of the war on drugs in 1971 under Nixon. And, that marked really a concerted federal focus, both in terms of criminal justice, reducing supply of drugs into the environment, as well as demand reduction, actually. But of course, the war on drugs is not typically associated with so-called demand reduction, that is prevention, treatment, and recovery, even though at the same time, there was a great deal of money allocated for research in clinical and the public health arenas vis-a-vis addiction. Notably, the birth of the National Institute on Alcohol Abuse and Alcoholism was founded right at that time. And then also in 1974, the National Institute of Drug Abuse. Both of those institutes have produced 90% of the world's research on addiction and what we've learned about it in the last 50 years. And we've learned a great deal in terms of etiology, the factors, the causal factors. We know that, for example, now that there is a strong genetic component that influences risk, just like other complex illnesses. Substance use disorder addiction is no different. Some people are more protected, some people are more vulnerable. It's not genetic alone, of course. There are many other factors, including availability, of course, of substances in the environment, key factor, of course, when we're talking about substance use disorder. Also, neurobiology, the impact in the brain, how it affects the brain's neurocircuitry, and why this is a psychiatric disorder, why it's classified as a psychiatric disorder because of the involuntary nature. It doesn't start off like that, of course, but it becomes involuntary where people end up using it against their will. Also, the epidemiological risk factors, the protective and risk factors that promote or reduce risk, as well as the pathways into, through, and out the other side. And of course, in the last 50 years, we've developed a lot of pharmacological treatments, as well as other kinds of psychosocial interventions, detoxification procedures, and protocols to help stabilize and provide acute care treatment. One of the other things that we've learned is that the clinical course of these disorders tend to take a long time to remit and stabilize in remission. You can see here on the left-hand side, it takes about 5 years after people meet criteria for an alcohol or other drug use disorder before they start seeking help. After which time, when they do, it can take about another 8 years and 4 to 5 treatment episodes or mutual help organization episodes before they reach their first year of remission. That's quite a long time, about 8 years in adult clinical samples. And then another 5 years before that person is at no greater risk than anybody in the general population of meeting criteria in the following year for an alcohol or other drug use disorder. So it takes 5 years after initial remission before the risk is no greater than anyone else in the general population of meeting criteria for one of these disorders. So we're talking about a disorder which tends to have a chronic course, But here's the good news, most people do remit. 60 to 75% of people with these disorders will eventually get into sustained remission. So these are actually good prognosis disorders. I'm not discounting, obviously, the misery, human misery, and premature mortality, which are tragic and unnecessary. But most people who have these disorders will eventually get into sustained remission. The challenge, of course, is how do we get them there sooner? What are the factors involved in supporting earlier remission and sustained stable remission earlier? Well, we know there are two facets to that undermine recovery attempts, and they're neurophysiological as a result of the chronic impact of exposure to these abnormally high levels of toxicity and reward by way of drugs. And this produces, when you remove the drugs, it produces this hypersensitivity to stress in the human organism when you remove the poison in the early weeks, months, and even years for some people, as well as a down-regulated capacity to experience normal levels of reward. So they're stressed out and they're unable to experience normal levels of reward. That's not a good combination. This is why it's so important to provide the right kinds of environments that are conducive and supportive to recovery. And these environments tend to be socially oriented environments that are populated oftentimes by peers who have the same lived experience. I liken this to kind of the way that plants recover from disease through photosynthesis. You can have genetically identical plants placed in different environments can have very different outcomes. And placed in the right environment, with the right light and soil, the plant can not just survive, it'll thrive and flourish. I liken recovery to a kind of psychosynthesis, a way when we place the human organism in the right kind of context, a conducive and supportive human environment, typically a social environment, then that human organism can absorb the nutrients from that social soil and be able to not just survive, but actually flourish. And this is what we see with people in recovery. Mutual help organizers, as you can see here from this array of different entities, there's been a number of these recovery services that have started in the last 80 to 90 years in the United States and around the world. The oldest mutual help organizations in the modern era started with 12-step organizations like Alcoholics Anonymous, but many others now have started to help people who have these disorders as well as family members. And you can see the array of other kinds of modes, other kinds of services like recovery coaching, recovery housing, physical and recreational recovery supports, recovery community centers, collegiate recovery, recovery high schools. We learned a lot about the utility, the clinical and public health utility of these resources. There's been a lot of confusion about how useful certain resources are that are peer-run. The biggest and most famous, of course, is Alcoholics Anonymous. It's the biggest recovery support service in the world. It's the most frequently sought source of help for alcohol and drug problems worldwide. We conducted a review, a systematic review, a few years ago. We published it in 2020 and really clarified, these were all randomized controlled trials that were clinical trials whereby patients with severe alcohol addiction were either randomized to receive a linkage to Alcoholics Anonymous or to receive another kind of intervention like CBT or other kinds of empirically based interventions. And what we found quite remarkably in this review, that this linkage by clinicians to AA for people with very severe alcohol addiction produced 20 to 60% higher rates of remission over 3 years relative to patients who were randomly assigned to receive another kind of intervention like CBT. You can see here in yellow the relative advantage of being linked to, in this case, AA, producing higher rates of remission. On every other outcome, they were either the same or better, as well as dramatically reducing healthcare costs. So not only does this linkage to peers with lived experience in the environment in which people live, are able to produce higher rates of engagement and remission, but at a substantially reduced healthcare cost, reducing the overall healthcare bill for alcohol use disorder by $10 to $15 billion nationwide in 2018 dollars. Now, that's just one example where we've got very good evidence now in terms of mutual help support, but not everybody, of course, wants to go to Alcoholics Anonymous. So what do? Well, I liken the, I use this metaphor of a fitness center to make the point here. The question I often ask audiences is, do fitness centers keep people physically fit? And the answer is, well, yes, they do if you go and you work out and you go regularly. So fitness centers know this, of course. And when you walk into a fitness center, you don't see 40 treadmills and that's it. We know treadmills will work to keep people fit, but not everybody wants to use the treadmill. So instead of having 40 treadmills, they have 40 different classes, pools, courts, all kinds of fitness activities and equipment to try and attract and engage people into some kind of activity that can support physical fitness. Do mutual help organizations work? Well, yes, if you go and you participate, they do help people. We know this to be true. We've got very good evidence from AA that AA works, produces higher rates of remission over the long term, reduces healthcare costs. But again, not everybody wants to go to AA. So again, we need to increase the repertoire, the menu of options that people can become engaged in. That's their flavor of recovery support. Now, it may be true that Alcoholics Anonymous is kind of the cross trainer. It's the quickest way to get fit for recovery, maybe. We know it works. We don't know if it works better than other mutual help organizations, but we do have evidence that when people self-select into one of these mutual help organizations, when they choose something that they like, in other words, they do well. They do just as well as people who choose self-select into AA. So this is important. Again, using that fitness center analogy, is that people need something. They need to find something that will suit them, that they can say, well, that's not for me, but this is, and I can get engaged with this. And all of these organizations are populated by peers with lived experience who have gone through the same thing, are going through the same thing, and are getting better. And this is the power of peers. It's the power of peers. And it's very powerful, as I showed you there with the research on AA, extremely powerful as professionals delivering bona fide treatments that are well grounded in psychological theories of operant and classical conditioning. These peers are able to confer benefit through this engagement over time in the communities in which people live. How do they do it? How do mutual help organizations confer this benefit? We know there are common factors, these common factors across all peer support and groups of people in therapeutic environments. And these are many of them here. I like this set of so-called curative factors that were detailed by Irvin Yalom. He's a professor at Stanford who described these principles, these therapeutic ingredients of involved in group therapy. And he described these processes of universality and altruism, catharsis, and installation of hope. In other words, universality is that feeling of belonging, that I'm like these people, I'm the same, I have the same thing. That's a great relief to know that you are not alone. Just that very fact that you're not alone. Other people are there, visible in front of you. They've suffered the same thing, are going through the same thing. And some of them have gotten through it and benefited from this process, are through and are living in recovery or in a better state of functioning in mental health. And that can also decrease personal stigma and shame that people often have, just to know that they're not alone. Installation of hope, again, the idea that I can see visibly in front of me people getting better. These are active role models in front of me who are doing well. They're coping better with their lives, and that's can instill hope. Imparting information, cohesiveness, altruism, giving it away to keep it, as is often said. Helping somebody else helps me. Catharsis, being able to talk about, ventilate mentally, emotionally, what's bothering me, to get support around that. These are major processes that go on in all mutual help organizations. We also know from very sophisticated research that's been conducted on Alcoholics Anonymous, again, AA, because AA is so large and there's so many people, over 1 million people that go every year, nearly all the mutual help research so far has been conducted, sophisticated research has been conducted on AA members. And these are the empirically supported, evidence-based processes through which AA has been shown to confer benefit. AA works by, in other words, helping people shift their social network principally. And it's that change in the social network away from alcohol and drug using individuals towards abstinent recovering individuals that then facilitates these other processes of change. You can think again of these social networks as the soil. It's the soil, to use that photosynthesis and psychosynthesis example. It's the soil through which these other nutrients, recovery nutrients, are absorbed. In other words, self-efficacy, confidence, motivation, coping skills, reductions in craving and impulsivity, and improvements in spirituality, which can be helpful for people to cope in different ways with stresses and find new meaning and purpose in their life. We also know that recovery, as I mentioned, 60 to 75% of people who have these disorders do recover. And this is what it looks like in recovery when people get into recovery. This is a sample, nationally representative sample of Americans in recovery. There are 23 million Americans right now living in recovery. We're surrounded by tens of millions of people in recovery. And this is what happens when we zoom out and look at over a 40-year period, what happens to people's lives in terms of their quality of life, functioning, happiness, and distress. And you can see year on year, these benefits accrue over time. So as people go further along in their recovery, they get better and better in terms of their functioning, quality of life, happiness, self-esteem, as well as decreasing psychological distress. This is even controlling for age. So as, believe it or not, as we get older, we tend to get a little bit better in terms of our happiness and well-being overall in general. But even when you account for that, you still see these benefits year on year, with this steeper increase in the first 5 years. As you can see on the left-hand part of the graph here, there's a steeper increase in these indices. That maps on also to what I said earlier about that 5-year time frame before the risk is no greater than anybody else in the general population of meeting criteria for a substance use disorder in the following year. So you have a similar pattern here being demonstrated, being shown in terms of that first 5 years. There's something about that first 5 years of readaptation or adaptation to the demands of recovery. Again, facing those neurophysiological challenges inside the person that they have to deal with that can undermine their attempt, but building, getting the access to the building materials that they need to rebuild their lives and the building permit. It's interesting also, just end with this, when you look at recovery under the microscope, this is just looking at the first couple of years. It's not smooth sailing. So here we're looking out on the right-hand side here, just the first 2 years. And if you look at the first year, the first left-hand side of that graph, you can see that there's a period of convalescent stabilization there, followed by a drop. A little drop there in quality of life and functioning the second half of the first year among people who are recovering. Interesting. I think what's going on here is this kind of, after this period of, maybe this could be treatment, maybe a lot of attention from family and friends or peers, there's a dawning of reality that goes on here for people as they look around and they start to, the fog starts to clear in their mind and they start to say, wow, okay, I'm stable now. Look what I've got to clear up. And they look forwards and they say, look what I've got to make up. And those two thoughts can be pretty daunting. Before this end of the second half of the first year, those indices start to improve. And the I've just mapped it out here in terms of kind of a preliminary recovery curve of what is happening in these early years of recovery and beyond. And you can see here that there's a kind of a recovery curve taking shape in terms of this initial convalescent period, kind of a dawning of reality. That's followed, if they can access the kinds of things that they need access to, the kind of building materials and building permits that they need to get started reconstructing their life, they can start to rebuild their lives and move forwards. Now, we do know that, speaking to Paul before the meeting, that anecdotally, we do have evidence that family members, when family members when they themselves get help, find help through counseling, peer support. There's loads of peer support groups for family members now, as well as evidence-based interventions that can help family members. Not only do the family members themselves become empowered and improve in their own functioning and well-being and decrease their stress. Again, the same dimensions apply, those universality, catharsis, installation of hope, all of those same therapeutic factors are operating in peer support for family members. But also their loved ones do better. The affected individual who is addicted, those individuals also do better. They get into treatment and recovery sooner. So that's the good news, is that we now have good evidence that, as you're probably feeling, in other words, there's a reason why you come back to groups like this, because there's something that you're getting. There's some ways that you're benefiting, whether that's exchange of information, feeling like you're not alone, being able to talk about what's going on, again, ventilate, catharsis, to know that you can get through this, you can get support. All of these things are operating in mutual help organizations. It helps people who go, and it helps the person indirectly and directly as well. Happy to answer questions on that. We do now have a good evidence-based intervention that works better than the classic intervention, the classic Johnson intervention, which is kind of portrayed on TV when you all get around and read out letters and make demands that the person get treatment. That can work about one third of the time, but there's a new intervention which involves more coaching and counseling by a therapist over 6 sessions that works about 70% of the time to get your loved one into treatment. So that's a big improvement. That's called the CRAFT approach, community reinforcement and family training. You can look that up. There is online video versions of that as well that you can get information about and learn to apply yourselves if you have an addicted loved one that you're close to, with whom you live, or that you're in close contact with, that you can use those same practices and principles and help your loved one into treatment. So that's good news that we have now a very effective type of intervention called the CRAFT intervention that can be helpful as well in terms of directly getting your loved one into treatment, to accept treatment, which can be a big deal, big challenge, of course, for families, is getting their loved one to accept treatment. With that, Paul, I'll turn it back to you, and then hopefully we can have some Q&A discussion.
Yeah, that'd be great. And I think it's best if people would just use the reaction. On my screen, if I click reactions, I can raise my hand. And we already have John Hamilton raising his hand. But let me just ask you, John, do you think there will be more studies into family support? You mentioned that AA has been the one that's had the most focus, but do you think, Al-Anon and support groups like our own and, parent or family support by treatment centers, do you think those are going to come under more study?
Yeah, definitely. Right now, there's a big focus on recovery support services, right across the board. We've had There's now a new Office of Recovery at SAMHSA, which is one of the federal administrations. And there's also a proposal for a 10% set aside of the block grants. That's the money the states get to provide treatment services, publicly funded treatment. And there is a big focus now on evaluating all kinds of recovery supports, including for family recovery support. So I'd say over the next 10, 20 years, we're going to see a lot of studies on all kinds of recovery supports, including family.
Great, thanks.
Yeah.
John.
Thanks, Dr. Kelly. Great presentation as always. With all the longitudinal studies being done, do we have enough benchmarking to actually develop adaptive treatment models? Because every program says they individualize care, but we really don't. And are we really tailoring it to some of the key ingredients in recovery capital? Have we boiled down those key ingredients in recovery capital that we should actually start with in a treatment experience to help the person stay engaged in a sustained recovery?
Well, you hit it on the head there, John. Nice to meet you. Yeah, it is. There are some general things that can be applied, but of course, each person is unique and has unique needs, and those needs, of course, change over time. As people change at different rates, they may adapt at different rates depending on their just physiology, their recovery capital in terms of, do they have a job? Do they have stable housing, safe housing? Do they have family support? Do they have other peer support, etc.? And people have varying degrees of those. So it's kind of providing access to those building materials, as I call them, when and if and when people need them. Like, it's kind of who needs what, when, for what duration, at what intensity. Who needs what, when, for what duration, at what intensity. And I think we need the kind of the menu of options available at each phase, that each person who is in need of those services can tap into them rapidly, quickly, and to be able to make those available for folks. Yeah, so it's better that we provide the menu of effective options and let people choose. That's what it seems to be, rather than to be kind of pushing someone in a certain direction, but rather ideally have, as we've shown with mutual help organizations, when people can find one that they like, they do as well. They'll do better than if they're assigned to one they don't like. So if people can choose an array of options, then they will do better. So we just need to do a better job of providing more of these services, make them kind of on demand, ideally available, so that people can access them when they need them, for the duration that they need them. Now, that sounds expensive, but the cost is much worse. The cost of clearing up the wreckage, it far outweighs anything that we would spend on providing these kinds of services up front. As you may know, for every dollar that we spend just on treatment, we save $4 to $12 in societal costs. So peer recovery support services and other recovery support services, which can support people after that more expensive acute care, hospital stay, and clinical treatment, are much more cost effective. And this has been shown in studies of AA, recovery housing, that these other services are just as, if not more, cost effective. So that's the good news, if we have the political will to supply them, and that's under the current administration, that's been present. Of course, we don't know what's going to happen in the future, but there's been some good news on that front.
Great, thank you. Thank you, Dr. Kelly.
Eric, you have a hand up?
Yeah, thanks. I'll lower my hand now. I have some kind of basic, simple questions. And maybe it's because I'm not familiar enough with acronyms, but The first one is in an early slide, you talked about a period of time after initial remission. Are you talking about initial sobriety and beginning of recovery? I assumed that, but just wanted to be clear. Yeah.
Mhm.
Um,
Yep. Mhm. Yeah, for the most part, that's right. Yep.
Yeah, and I should preface all my questions by saying that I'm really impressed by the fact that there is long-term empirical study being focused on this area. I applaud you for your efforts. I think it's terrific. A lot of this stuff is known to many of us anecdotally. It's nice to see some empirical study backing up what we believe is effective. There's an acronym AUD, Mutual Help Alternatives for AUD. What is AUD?
Sorry. Yeah, sorry about the acronyms. Yeah, alcohol use disorder. So
Okay,
that's kind of what we used to call alcoholism. Yeah.
yeah, I assumed it was disorder. And AOD, same thing?
Oh, sorry. AOD would be alcohol and other drugs.
Okay, okay. And then there was one last one, empirically supported MOBCs. What are MOBCs?
Oh, mechanisms of behavior change.
Okay. Thank you. Just helpful to know what those are on the slide. That was all for my questions. Thanks.
Yeah, sorry about that.
Steve? You're on mute, Steve.
Here I am, obnoxious. Thanks, Doctor.
Oops.
So my question, very similar to the last question here. So in one of your original graphs, you talked about, I think, 4 to 5 years of priming. Was that where you had all the squiggly signals up and down for the first year or two?
No, that's that 4 or 5 years. That's the number of years it takes on average after people meet criteria for a disorder, for an alcohol or other drug use disorder, before they start seeking specialty help.
So they're not in Alcoholics Anonymous during that time? Or any
No.
program? Oh, okay.
On that timeline, that first timeline. So that's before, so that takes about 5 years. So they already meet criteria for the disorder, but they're not seeking help yet.
Okay. Yeah, I was kind of thinking maybe if they were seeking help, then falling off and coming back. So I was wondering,
That's in that 8-year time frame, in the middle.
Okay.
Yeah.
okay. So each time they fail or they don't stick with it and come back, do they start over? Or they wanted to come back, so maybe they're up higher on the recovery
Yeah.
line? They
Yeah,
come
so
back?
typically what happens is on that process is that people get longer and longer, on average, longer and longer periods of abstinence.
Okay,
You get longer and longer periods of absence and stability after each treatment or mutual help episode. And then until they get that first year, that's 12 months, no symptoms.
right, right. Yeah, no, I mean, in my case, I've seen, it strongly recommended that to get into a program like that, and they might not buy into it yet. So I was just wondering whether that takes into effect people coming to the program, leaving, and then coming back maybe when they really want to commit to it. And the other thing is, maybe you can send these slides to Paul, but can I get a copy of these slides so I can look at it a little more carefully?
Mhm. Yeah, feel free to, Paul, to distribute them.
Okay.
Thanks, John.
Okay. Yeah, I think that was it. I mean, the power of peers, it's important to me. I mean, I sit in on 3 calls each week, and it's just kind of the community of people who are experiencing the same kind of situations and problems. I think it's certainly powerful for parents or spouse of loved ones in addiction. So that was it. I just wanted to comment and say thank you very much. Thank you.
You're welcome. Thank you. The other thing to remember is, even if someone does not get sober right away after a treatment episode, oftentimes seeds have still been planted. When you follow people up over time, people who get those interventions, who get that treatment, regardless of what happens after, when you follow them up over, say, 10 years, 10, 15 years, those people who've gotten more treatment, irrespective of how they responded, get into remission much earlier, substantially earlier.
Yeah.
So you're planting seeds every single encounter, every conversation that you have with someone who's affected. every clinical encounter, even when you think they're not responding, just by virtue of the fact of being there, they've heard something, a seed's been planted, it tends to get people into remission sooner. And we see this in many different studies. So that's the good news. So don't give up hope, because if they're getting some exposure to some kind of conversation or clinical encounter, that is ultimately going to be helpful.
Yeah, no, I was just gonna say, seeming hopeless, it's not. I mean, you're gradually making improvements, but thank you.
Exactly. Yeah. But I don't know who's next. Was it Howie or
Howie?
Stephanie?
I think Howie's next.
Yep. Thank you. Thank you, Dr. Kelly, for taking the time and the presentation. Next to AA, which recovery program in the research has the most efficacy?
Probably Narcotics Anonymous.
Besides Alcoholics Anonymous?
Yeah,
What would
so
be
NA, Narcotics Anonymous. So
okay, okay.
yeah, so the next one would be, the next most research would be NA. That would be the next most kind of evidence, most evidence supporting it as a viable recovery support service. There's very little on other groups yet, very little empirical. But here's the thing, as I mentioned, it's not so much about relative efficacy. As I mentioned, it may be that, AA is the cross trainer of recovery fitness, to extend that fitness center metaphor. It may work quicker or better in getting people fit for recovery. But if nobody's using that piece of equipment, then nobody's working out for recovery. So this is why having these different options that people can work out and get fit for recovery on, like Smart Recovery, like LifeRing, like Women for Sobriety, like all these other online recovery support services as well, new ones that have cropped up in the last few years, provide different flavors, just different flavors that are palatable for different kinds of people. And that's more important than relative efficacy, because, as they say, 10% of something is better than 100% of nothing.
Mhm. Thank you.
Yeah. Stephanie?
Good evening. Dr. Kelly, thank you so much for joining us. And Paul, thank you so much for providing this opportunity for all of us to virtually meet Dr. Kelly. It's, very, very special. I've heard such wonderful things about you from colleagues and friends, both Cindy Shaw and Trey Laird. Full disclosure, as a recovery coach and an individual in long-term recovery, I did not go to treatment. As my pathway to recovery is AA, 23 years. So I feel well-versed in certainly that program. And as a coach, what's been fascinating for me and what's broadened and deepened my own recovery is being taught and experiencing other pathways. I have clients, male clients who are in LifeRing. I have female clients, Women for Recovery. It's lovely that there is this cross-section. What I really wanted to ask you about is, so oftentimes, whether an individual has been in and out of treatment 3, 4, if not 5 times, and then potentially in sober living, that it is when the recovery coach, my experience is, and what I've been told is that when the recovery coach is added into the recovery recipe, whether that's a discharge or by virtue, like the Lighthouse, where each resident is given a coach, that the difference is made in that there's I want to say maybe the change agent is too big of a term, but there is a shift when there is the working connection with a recovery coach. So we talk about the continuum of care. And like I said, I am not anti-treatment, and I fully understand why it's an acute care model and why there's symptom management and how important that might be. But I'm just going to say something bold. I've said it before. I wish for this world that the lion's share of the funding and money wasn't spent on treatment, but it was spent on the aftercare, on the continuum of care, on the recovery support services for the individual and the family post-treatment. So, that's a big shift because there's big business and big money in treatment. But as a recovery coach, I want to be able to shout from the rooftops. Does everybody know that, and this is, William White, does everybody know that 80% of people who discharge from treatment relapse in the first 90 days, or 75 to 80%? That's a big number. And when a recovery coach is introduced to the mix, that percentage shifts dramatically. So I guess my question is, how can we let more people know about the efficacy of recovery coaching? How can we help individuals shift thinking to, instead of just sending somebody back to treatment and spitting them back out again, what can be done to help people really be educated and informed and be given that good news that there is a difference when there's a sustainable recovery outcome when a recovery coach is introduced into the mix?
Well, first and foremost, one of the things that's powerful is what you just said, your own testimony and experience and observation. That is one. You're a powerful advocate, and you articulate it so well of the power of your experience bringing to bear flexible. It's providing that flexible, continuing support that's accessible and available. And people need that, like in AA, where they have the sponsor model, that flexible, accessible peer support 24/7, round the clock, 365,
Right.
And particularly at times when professional support is often not available, like
Right.
at weekends, evenings, and on holidays, when people really need support, peers can provide it, or recovery coaches can provide it. Now, so that's one piece is testimony like yours, being able to articulate it as you have done so clearly, powerfully. And then also the research that has been done, is being done, will be done over the next 20 years. As I said, there's a pile of money now being put into really looking at this. It takes a long time for these things to shift, for people to really get the message. You're on the front line, you see it. And it takes a long time to get movement, culturally, scientifically, for the world to see that. And it takes people like you keeping your foot on the gas, talking to people, asking the right questions, advocacy, joining things like your state organization for recovery, your state RCOs, recovery community organizations, to lend support to the voice, collective voice and coalition in your states that will have advocacy at the state level and then at the federal level to make those changes. Because I agree with you, we spend way too much money up front, inordinate amounts of money that could be just even, a quarter of that being put into recovery, continuing care services would go a huge way to improving remission rates and stabilization sooner. That's why I give talks like this that really focus on that linkage being key, and it's low cost, it's cost effective. And these data points now are beginning to influence people.
Thank you.
Yeah.
Thank you.
Thank you. Who's next? Was it Jacqueline?
Allie?
Ellie?
Hi, thank you, Dr. Kelly, for your presentation. I really resonated with your graphs, especially it was very validating for my own recovery journey, especially when you showed those low moments of the first 1 to 2 years. I feel like for me, in that period of my life, there was a lot of pressure to just be happy. You're in recovery now, you're healing, why aren't you happy? You're getting these things back when, it wasn't so easy as just be happy. And I guess that leads me into two questions for you. Originally it was one, but it morphed. My first one being that since those low moments are often issues with underlying mental health struggles, or maybe an undiagnosed or untreated mental health issue or trauma, usually that's always what it ends up boiling down to. What has been your findings on peer support related to mental health and things like peer-run respites and programs like that? And my other question is, what has been your findings doing this research with harm reduction efforts?
Well, thanks for your question and your comments, Ali. Good to meet you. Yeah, what was I going to say? What was the first bit of your question again? Getting old.
What have you found with peer support related to mental health peer support and peer-run respites?
Yes, so yes, there's been tons actually of much more research on peer support in the mental health field writ large, more broadly, more support there for peer support recovery models in mental health. And there's lots more studies there that have been done than in the addiction field. So we're kind of in the addiction field, we're a little bit new to that empirical emphasis on evaluation of these models, but they've been adopted in mental health for a long time and supported and are part of the mainstream infrastructure of recovery, community recovery support services. So we've got a lot of catching up to do there. They work very well, they help people. We do know, as you pointed out, that many people, roughly half of the people coming into treatment have a current comorbid psychiatric disorder. Most typically that's a mood or an anxiety disorder. Some have traumatic histories, about a third, and about 20% will meet for PTSD, so have post-traumatic stress disorder. So all of these things, and you're quite right, once you remove the alcohol, the drugs, the toxins, then yeah, those things can become better, they become more manifest, more visible, as well as more treatable. And so that's a time when we can address other kinds of comorbidities, psychiatric and medical, during those times. And it can be when that unmedicated trauma needs to be treated because that is no longer being medicated through substance use. So that raw emotion can be a risk factor that can send people down in the dumps, and place them at risk. So those are important. And then the harm reduction, the harm reduction piece, we don't have a lot of peer support as such for harm reduction services, if that was the question, but we do have a lot of community-based, of course, service workers that work in harm reduction services in the community, particularly in the opioid crisis with needle exchanges and even with naloxone distribution, Narcan distribution, and so on. Fentanyl test kits now can be paid for as well in those services. So those are peers typically themselves in recovery who are doing that work. So it works in that way.
Thank
Jacqueline?
you.
You're welcome.
Hi, thank you, Dr. Kelly. I am a newly hired family recovery coach, trying to launch or help launch a family recovery program. And I find it very interesting, the graph that you showed, again, what Ali was talking about, the 6 months into remission recovery, how there's a little bit of a dip there. And I think that's also where family support can tend to dip, because they the expectation is, I want you to be better already. It's been 6 months, you should be better. And so I'm wondering what kind of family support can we give to keep family members involved and to manage expectations, especially at that 6 month to a year mark?
Well, that's a great question. That's a great question. Yeah, the kind of there can be impatience on both sides. There can be,
Mhm.
impatience on the kind of the person who has the disorder in recovery side, where they feel like they're not being trusted soon enough. They feel like they're doing a lot of work, and why aren't you trusting me? There can be that kind of impatience on that side of things, as well as the other side from the family members. Kind of, there can be impatience, and there can also be trepidation in terms of kind of walking on eggshells. What should I say? What shouldn't I say? When is he or she going to relapse if I say that, or if I confront them about that, or if I ask them to be more accountable or be more responsible, or take up some of the responsibilities that they had before. There can also be, as you may know, there can be readaptations in the family system as when you remove the substance out of the environment, then there can be difficulties in expression of emotion, because sometimes the alcohol or another drug facilitated expression of emotion. When that's missing, now they have to readapt and readjust to how do we express emotion with each other? How do we express intimacy again? And all of those things can be big challenges, and because these addictions can go on for years, if not decades. And so that can mean a big readjustment again. So all of those things are all in the mix, and have to be thought through sensitively, carefully, to help people navigate all of that, understand what those are, and then help them just navigate through that. Ideally with someone like yourself, yeah.
Thank you so much.
Yeah, you're welcome.
John-
Thanks for the question.
John, I just had a question about all the treatment centers that are out there that come out with the statistics to justify why you should go to that particular treatment center. But it's a little bit funny that the data they provide all seem to show 95% efficacy in success rates, however you determine it. And we know that's not really the case. And, I guess this is for people that complete a program of some kind. But do you find that the data can be misleading compared to the kind of data that you provide?
Yeah. I, be very skeptical, be very, very skeptical of, those are impossible outcomes. The truth of it is, if that was really true, if you could send people who have these problems to those centers and that 95% cure rate or remission rate after whatever it is, 30 days or 60 days or whatever, we would be building them all over the place. We'd be recreating them. If that was really true, everybody would be knocking on the door from around the world saying, how do you do this? That's why it's not true. It's impossible that they're doing that. And so they're just, making up numbers to get people in the door. And it's sickening. I hate that. I really think that's misleading. And, those programs should be ashamed of themselves for putting out numbers like that, which are flagrantly false, and they know it. It's misleading, and they're putting out false hope. And there's no way that 95% of people who go through those programs are in recovery or remission, whatever it is that they say a year later or whatever. So yeah, it's really unethical that they do that.
Yeah, Jacqueline? Oh, okay.
Yes, hi,
Eric?
Oh,
Okay,
sorry,
go
I
ahead,
just,
Jacqueline.
very, very quickly, I find it very interesting. This is the first time I've actually heard the word remission used in terms of substance use recovery. And I think it's great because substance use disorder is a disease, and using remission, I think, is actually great. Language matters. And I'm just wondering, are you seeing remission being used more among, let's see, not just among clinicians, but among the general public?
Well, it's interesting you note that, because I mean, the habit of talking about remission, because that's clearly delineated and defined, so we know exactly what that is. Interestingly, there's been a movement in the opposite direction towards recovery, talking more about recovery, and in fact, providing an operational definition of recovery. But I think, I use the term recovery loosely as well, because a lot of people understand the general meaning of that. But I probably use remission more, just because that's well defined and delineated. And like you said, when we're talking about these psychiatric disorders, then it fits with that model. Eric?
Yeah, I just wanted to follow on the Paul's question and your comments. I'm not familiar with a lot of programs that run a 30-day model and claim a 95% success rate. So I think we have to be careful what we're talking about and who's saying what. Both of our sons went through treatment programs that were 6 to 8 months long and 12-step focused, and have continued with tremendous peer support in their recovery for the last 3 years. So, and they will both tell you that anybody who says, I went to rehab for 30 days and I'm cured, is full of it. So just a comment, not a question, really. Thanks.
Thanks. Glad to hear about your sons doing so well.
And also, John, wouldn't you also say it's difficult to disentangle like how a particular treatment center is doing from the fact that most of them are saying you need to go to 12-step meetings, over this long period of time, you're at 12-step meetings and while you're going to the treatment center. So it is hard to disentangle, and so maybe that's one reason that they can make a claim, but it's not necessarily the treatment center as much as a lot of these other supports, like to Eric's point, that you're doing it for a longer period of time.
Mm-hmm. Yes, exactly. Yeah, it's much more, about, what you do after that first 30 days. Yes, that can be life-saving. The detoxification and stabilization piece, that is expensive. That does require medical management for those who need it. Not everybody needs that either. Then what do you do then? That's the thing. When you're talking about an illness which is susceptible to relapse, over really 5 years, the risk is elevated, remains elevated. Now it goes down gradually over that 5-year period till it drops after 5 years to below 15%, which is the same risk in the general population in any given year to meet criteria for one of these disorders. That you need that ongoing, flexible, accessible, affordable support over the long term. This is where groups like AA and other mutual health groups are just an excellent match for the undulating course and the risk. The flexibility, availability, accessibility, affordability, all those things are key when we're talking about these high volume, high burden disorders. That's why I talk about like AA and groups like it as the closest thing public health has to a free lunch. Groups like you, what you're doing is the closest thing public health has to a free lunch. We get all these free things in the community that are run by peers that we don't use as fully as we might by really connecting the dots. This is why, there's people talk about this recovery-oriented system of care. It's really connecting the dots between our clinical services, our criminal justice system, our medical services and treatment, addiction treatment, to all these other services in the community, which provide the ongoing recovery support, which prevent relapse over the long term, because that's what we need. We need these ongoing services that are local, accessible, flexible, et cetera.
Yeah, and John, just wanted to say, it was, I think, eye-opening for a lot of us to see the length of periods of time that you had in those charts. But that the charts, that 40-year chart up to the right, that to me is a very hopeful chart, that as people stay in recovery. And I think you're implying by that you in the later years, as you're continuing to go up to the right, you're in a different place than you were if you didn't have the disorder and go into recovery to begin with, that you are actually have improved yourself in different ways and in your satisfaction in life by going through this. Is that right?
Yes, yes. I can tell you, anecdotally, as well as actually, people will tell you, and I'm sure you've experienced it yourself as a function of doing what you're doing, is that there is a kind of, it's not self-actualizing in spite of, but because of that you've experienced these things, that you start to really flourish and thrive. And people report when they get into recovery from something which has been life-threatening or really impacted their life, whether it be cancer or addiction, there's a new kind of technicolor version of life. There's a kind of an more intensified version of life, which is, they feel more alive. They appreciate, they've got more gratitude, a sense of gratitude for their life. And that kind of attitude of gratitude and that positivity comes through in their life. And this is what people often report.
Well, awesome. I think that's a great way to end it. And would anyone else out there want to join me in thanking Dr. John F. Kelly?
Thanks so much, Paul.